Hello, so this is Drugs in Perspective, Chapter 12, Alcohol, Drug Recovery, Co-occurring Disorders, Suicide, and Alcohol Drugs. Introduction. Approximately 1 million people in the United States currently receive treatment for drug or alcohol addiction. This chapter gives an overview of alcohol and drug treatment and relapse prevention. Sobriety from alcohol and drugs is an ongoing process. This chapter highlights treatment issues and approaches for specific alcohol and drug and co-occurring disorders. You are encouraged to explore referenced material, take courses specific to alcohol and drugs, and pursue supervised internships for more in-depth counseling skill development. The most widely used approach for recovery from alcoholism and drug addiction is self-help groups. Alcoholics Anonymous was founded in the early 1930s by Bill W. and Dr. Bob. Both men found that willpower alone was not enough to make them stop using alcohol. They soon discovered that others had the same experience in struggling with recovery from alcoholism. Small groups of alcoholics met on a regular basis to share their experience, strength, support, hope, and support one another. In 1938, the basic principles of AA were outlined and became the 12 steps. So, advantages of the AA as a recovery model. Lawson, Peterson, and Lawson outlined the following key factors that contribute to the success of AA in helping alcoholics/addicts stay sober. So one is mutual sharing by members, which provides solution to alcohol-related problems and helps alleviate guilt by showing members that others have acted irrationally also. 2, provisions of a regular support group of individuals working toward the goal of abstinence. 3, frequent and regular meetings to help members structure their time. 4, availability of AA as an adjunct to other treatments, such as counseling and psychotherapy. 5, absence of membership fees and non-discrimination by race, sex, or socioeconomic status. And 6, establish a comprehensive goals covering the emotional, behavior, and spiritual life of the members. Resistance to attending AA and other self-help groups. For a variety of reasons, individuals in early alcohol and drug recovery often resist attending self-help meetings. Some of the reasons they give are the following. Difficult with the concept of a higher power of references to God. 2, lack of tolerance by self-help members at times to use medications for effective or dealing disorders and other psychological conditions. 2, help understand that there are different types of alcoholics. And 3, reject treatment. And then finally, number 3, people are uncomfortable in group settings and are connected with groups concerned with the groups maintain strict confidentiality. And 4, the disruptive influence of people who don't have a true desire to be sober. So, rational recovery.
I don't know if all of you or any of you are very familiar with rational recovery, but I can summarize and just simply say that we've been around since about 1985, that we have been pioneering avenues for addicted people, and we're interested in getting some of our perceptions of the nature of addiction and the nature of recovery to public policy bodies like this so that we can possibly bring about some changes that would add to the options that are available to addicted people. Some of those people, who keep coming back, might do better on their own than with the services that are available to them.
So you've been to treatment. You were a member of 12 Steps.
Yeah.
Did they ever explain to you how people actually recover from addictions?
You don't recover from it. It's a constant struggle every day, you know.
There's a profound discouragement that goes on with these frequent flyers. They go around the track again and again.
I'm curious as to, like, statistics, success rate, percentage-wise.
How would you respond to the criticism that, basically, your approach is flying at the face of a lot of the research that has been conducted by Stanford and Harvard and a lot of these universities that...
Why don't we give informed consent and let people know that this is a hotly debated issue? I believe it myself, and I will never drink again, Your Honor. That's the way we do it.
Oh, yeah.
Yeah, and we want to get to Your Honor. We do want to get to Your Honor, believe me.
Just walk me through it.
Okay.
I would come to you as a client, I would pay you, I would do what? How long is your
we want to
program?
provide no services.
Do you think that people ever just quit?
When very severely addicted people do this, they get better.
Have you ever heard of rational recovery? A lot of professional people know about it, but for some reason they don't tell enough people about it.
But at least let the people know that there is a group of people who believe in you.
What is exactly a normal abstinent person, anyhow?
I fear for this type of program that would feed into that belief system that I am a failure because I don't have the willpower to do it.
All we're saying is that when it gets to a certain point, though, people need an ability to opt out and say, look, I don't get this, I want to do it on my own. I don't want to be required to affiliate with a recovery group.
You're like our last hope.
Now, let me interrupt
He's
just
not
for a
gonna-
second. This is what we hear about 8 times a day. You are our last hope. You're the last house on the block.
So what would be your approach to dealing with relapse?
Well, you just opened a big political can of worms right there.
And what we want to do is give people the freedom to obey the law. Okay, the reason I'm getting picky on that is because this is the missing link in public research. What we want to do is to make it possible for some people to abstain from alcohol and drugs. He would be called in denial, and there's this underlying theme that says, "Yeah, let's see, it's not over till it's over, buddy." And I've heard that for many years, but it's he's better. I'm better, and it's a very ordinary thing.
Everybody started in the 12-step foundation.
It's
okay. It's okay.
Can I-
Stay open-minded.
Wait a second.
Stages of alcohol and drug recovery. Stage 1, early stages.
Hi, this is Judy Salinger from Lasting Recovery, San Diego's premier outpatient alcohol and drug treatment center. And today we're talking about one of the things, first of all, that I'd like to say is that through these 3 stages that we'll talk about, for a male, it generally takes on average for alcohol to get to the point where it's really severely problematic is about 15 years. And for women, it's about 8 years. Now, that's when we're talking about alcohol. If we talk about drug addiction, it comes much more quickly because of the destruction to the family system, the destruction to the body, and to one's surrounding life. What people will find is that they're drinking more than just a couple of glasses of alcohol. With wine, they may have 3, 4, 5, or beers, upwards to more than just a couple of beers, and that they don't realize that they've been doing it, but they recognize that their intake has significantly increased. Alcohol, because of the damage that it and drugs, the damage that it does to the brain and body, is that it creates us being more anxious. And so there's a lot of anxiety that goes along. So as the disease progresses, people want to drink or use drugs to calm their nerves, and they will often say, I was just so stressed that I had to use, or I didn't know what else to do when I got home, and it helped me unwind. The next thing that happens with people in this early stage is that there's a desire to keep on going when other people stop drinking or doing drugs. It's the people who do the cocaine, they go home and they're doing it at home, or people who are buying a bottle on the way home after they've had a few drinks with their friends, or the ones that stay late at the bars, or the ones that stay up late and drink or use drugs, beginning to do it by themselves. The other piece is an occasional memory lapse. And so it may not be a full blackout where people have a period of 2, 3, 5 hours or a day even when they don't remember, but there's memory lapses in what was said and done. And that's another sign of that early stage. There's this secret irritation when someone talks about, your use, asking you, do you remember? How come you don't remember what happened last night? Or I thought you said you weren't going to smoke marijuana anymore, and here it is. You told me that you threw it all away, and I see it again. Or the cocaine use, or the heroin use, and people, see foil in your room or needles or something. And so a lot of that can start with the early stage. The other piece then that begins is a rationalization. So people start rationalizing their behavior because they really didn't intend to use as much as they did. They just can't figure out how come they got carried away with it. So the rationalization starts, and this is the development of denial. And later we'll go into what some of the symptoms are. As the disease progresses, the denial even grows stronger. So thank you, and we'll be back again to talk about phase 2 of the progression of alcohol and drug addiction. Thank you. Hi, this is Judy Salinger from Lasting Recovery, San Diego's premier outpatient alcohol and drug treatment center. And today we're talking about Today we're in part 2 of the progression of alcohol and drug addiction, and we're going to be talking about a little bit about how it develops and what are some of the symptoms and how can you recognize it in yourself, or a family member might be recognizing it in someone that you love and care about. Our thinking becomes so distorted about the effects of what we're doing and the consequences of that use that we begin believing more of our system of denial, that it's not really a problem because we can't really do anything about it at that point, not consciously. So we find that that it becomes more useful for social affairs, that people don't want to go anywhere unless they're under the influence. People go and smoke marijuana, do cocaine, do these other things in order to get high before a specific occasion. having drinks at home before you get to the friend's house because you don't know when they're going to have drinks, and you might start going into some agitation, get irritable and anxious. Because at this point, the alcohol or the substances are really beginning to make an adaptation to your brain chemistry. And we use the term hijacking, that the brain has been hijacked. And so, in other words, the chemicals from the substances are attaching to the chemicals in your brain, and your brain wants to have it. I always think that it's like little Pac-Man in our brain saying, gimme, 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 you know? And it's the idea that this attachment is what drives you into more substance use. People find that this is called the loss of control stage. And in this loss of control stage, there's more blackouts, there's more embarrassing episodes. Sometimes people will find that they are so embarrassed by the behaviors that they have, or they've broken their rules of drinking and driving, that they won't leave home in their drinking. They will just stay at home, stay in their room. And so they buy sufficient quantities on the way home, for example, in order to have the substance use. And then they are in the process of developing rituals. And the rituals could start in the morning to remember that they have money in their pocket, and they know exactly where they're going to go at what time to pick up the substances to use that night, for example, on the way home from work. So there's a pattern because one of the things that occurs is that the desire for alcohol starts earlier and earlier in the day. So where most people think, well, I'm not an alcoholic because I don't drink at 9 o'clock in the morning, so therefore I couldn't be an alcoholic. But that's the next stage. So during this middle stage, people will start having preoccupation. In other words, they think about it maybe starting 12, 1 o'clock. They think about what they're going to drink, or they think about what they're going to eat, and then what they're going to drink with it. And that starts just as kind of a thought process that goes on to the point that then they have a hard time concentrating sometimes at work, so they'll leave early so that they can go have more drinks or go meet up with friends to do drugs. So it's a matter of the progression starting earlier and earlier in one's life. It's at this point that marriages get into trouble, relationships where someone is isolating, where they have personality changes. They may be gentle, sweet souls while they're sober, but when they're angry, when they're drinking. I had a man come in the other day, small children. He said, I couldn't believe it. He said, I picked up a plate and threw it up against a wall, and my wife's pregnant. He said, I would never have done that had I not been under the influence. And he and his wife decided that he needed some help and that it was a problem. So it's different kinds of situations at this juncture in middle stage treatment that will take somebody to call Lasting Recovery, for example, or call an outpatient treatment center to see if you can get some help and still maintain your job and have your relationships with your family. So at this stage can go on for any number of years. It just gets progressively worse. In other words, there's more substances consumed, there's more money spent, there's more damaged relationships, job losses, and that as we finish up that stage of stage 2. Next, we're going to be talking about stage 3, that final progression of addiction. Thank you. Hi, this is Judy Salinger from Lasting Recovery, San Diego's premier outpatient alcohol and drug treatment center. And today we're talking about today we're going to be talking about late-stage alcoholism and the effects of this disease on one's body, one's life, one's relationships with the world. And this is a stage that people get into if they've have not either addressed the alcoholism previously, if they've had severe enabling by family members who have continued to cover up the consequences, who have paid the attorneys and bailed people out of jail, who have taken care of them even though they've lost their jobs, who have taken them in when their marriage has failed. In this stage, in particular, the person's denial grows very, very intensely. The denial, the defensiveness gets stronger, angrier. It keeps people away, doesn't let anybody close. And the disease has really begun to take over more of the brain and the body. What we see at this stage is increase in high blood pressure with people, of which was also part of the stage 2, but it gets more severe in stage 3. We also see elevated liver enzymes, the startings of fatty liver, and cirrhosis is not uncommon in this late stage. What we see also is that some people are still working at a job, others have lost their job, some people are homeless, but most are living at home with their families, and they're being cared for or enabled by their family member or someone who helps to support their addiction. And the family members still feel utterly helpless, still trying to get them to go get help, and they're caught in the disease themselves. So the healing really begins when the family members reach out for help, and that they can see that they need some help themselves. And once they start to get help, then that process can begin. Sometimes when people are in this late stage, they will definitely go to inpatient treatment. They will go into 30, 60, or 90-day programs. Sometimes their DUIs have started to accumulate. They have, somewhere between 1 to 3 or more DUIs. Not all people have. Some don't have any DUIs, but it can be more progressive. And family members are disappointed, they're hurt, they're confused, they're angry, and the alcoholic often just, in order to be able to cope with life and cope with their drinking, is isolating. So they're drinking alone in their room, and people are basically ignoring them. And so it becomes a difficult situation for many families. And it's at this point that an intervention is very often staged, and that would be by the family members, maybe employers who's getting ready to fire this person, loved ones, children, grandchildren, everyone trying their very best to try to get this person to see that they love them and that there is a problem going on, and they just don't want them to die of this disease. There's this radical deterioration in the body, and unreasonable resentments that grows, and total loss of willpower, moral deterioration. People lie, cheat. There's just lots of conflict as the values that a person holds, their own sort of true spiritual values, are compromised, and they're in conflict with those. They may lose a family. Their impaired thinking, well, certainly we see sometimes someone come in and we have to do neuropsych testing on them because we can see that their brain has been damaged. There's something called Korsakoff's disease and Wernicke's-Korsakoff's, so that it's affected because people are drinking so much, and they're drinking and not eating, and they don't have sufficient helped with their brain and the vitamins and minerals and nutrients in order to maintain their short-term memory. And so that goes. And we've seen people come in here with that late stage. Now, what can a person do? If there's an intervention and the person seeks help, Certainly, there's always hope for people to be able to get to the other side. Doesn't have to be death, doesn't have to be mental institution, it doesn't have to be jail, but it can be a new beginning. And we really encourage families that, don't delay in doing, the work that you need to do in Al-Anon, for example. Alanon.org, A-L-A-N-O-N, Naranon, N-A-R-A-N-O-N.org. And those two organizations are support systems like Alcoholics Anonymous or Narcotics Anonymous for the person who has the substance abuse problem. Now, if family members will go to those organizations, they'll be with other people who tell them and help them to see as how they were able to work through and at least have their own lives, so that you have to save yourself at this point. I hope that this insight will help some of you to be able to make those decisions towards an intervention, towards asking someone to please seek help, to being willing to leave the person so that they can recognize that that you're tired of it. And very often they will seek help at that point. So I thank you for listening. And if you have any questions or comments, please feel free to contact us at lastingrecovery.com or to give us a call at 858-453-4315. Thank you.
Family treatment. Peter Steinglass outlined 5 major family modalities for alcohol and drug treatment. 1. Pure family therapy is based on a family system mode in which all family members are present at the same time in therapy session. 2. Individual or group treatment approaches fulfill specific criteria suggested by a family therapy theory of alcoholism, such as the concept of homeostasis. 3. Therapies involving concurrent therapeutic work with both alcoholic and family members rely on a more traditional individual psychodynamic theoretical base. 4. Specific therapies designed for a spouse or partners of alcoholics. 5. Supportive treatments assist non-alcoholic family members in dealing with common problems related to having an alcoholic family member. Advantages of a family system approach. It bridges the disparity between psychodynamic and stress reduction explanations of drinking. It explains diversity in alcoholic families by redirecting the focus from common etiology characteristics in alcoholic families to the common function of alcohol to maintain imbalanced family systems. 3. It gives therapists an understanding of alcoholism as a total systems behavior.
When I was working in accident and emergency as an adult nurse, I experienced as much, if not more, violence and aggression there than I've ever done in mental health settings.
The main way I deal with being faced with challenging behaviour is to ask myself, what is this behaviour about? And just in asking the question, you distance yourself from the behaviour itself and from your own emotional response to the behaviour. We encounter people who are distressed and then as a result might present with challenging behaviour. In mental health nursing, I would say fairly regularly, because we're working with people at a time when their mental health is suffering for whatever reason. So, and that is distressing, and people deal with distress and express distress in different ways.
It's often not personal towards us as individuals, but it's often an expression of what that person is experiencing, maybe the symptoms of the illness that they're going through. And I think it's just being aware of that, that we're aware that there is probably a cause, an underlying cause to why they might be behaving in a challenging way.
I think there were occasions, certainly with us working with teenagers, where we can see some pushing of boundaries, and we have to reinforce those. It's really, really important. But on the whole, I just try and stay calm. I just try and keep my voice level, and just try and redirect and try and diffuse the situation as best I can, really.
The main thing is actually trying to identify when it's going to happen, when it's likely to happen, and then try and avoid it. But when it has happened, then it's trying to find out why it happened so that we can try and prevent it next time. And again, is working as a team that really helps. Working as a team, talking to the person, finding out why, when they're a lot calmer later, just finding out why, and trying to find the ways that makes it better. Because I think it's also very difficult for them, as well as difficult for me and the rest of the team whenever I got into a situation like that.
I've got very good training in terms of conflict resolution and developed very good skills as a result. And also I've had experience of coming in contact with people that will present with various types of difficulties. And therefore, the very first thing that is important is to try and have a good understanding of why this person is behaving in the difficult manner, because that means there is a specific need that needs to be met, or maybe needs.
We also work with families as well who can become very, very distressed. And I think what I try and do is take a step back in that moment and remember why the person is there, why the families are involved, and I think just try and keep that in mind.
We talk at a very early stage with our students about skills of de-escalation, and to enable our students to recognise when patients might be becoming more emotionally aroused or having a heightened emotional state. And the idea would be that the earlier that they can intervene using good listening skills, good communication skills, awareness of body language, it might then stop a situation from developing and becoming more difficult.
What I found about working with people who may become physically or verbally aggressive is that this often comes from a place of fear or anxiety. And if we give people sufficient time to talk about those fears or their anxieties about where they are at or things they're experiencing as a result of their mental illness, that often can mean that they will find ways of expressing that which doesn't have to come through verbal abuse or acting out physically. And by no means is this a common experience. These incidents are rare when they do occur, and we do get great training to make sure that we manage them appropriately and safely.
I think we're human, aren't we? And when someone's, maybe very distressed or very anxious and is telling you that you're the reason that they're not getting better, or you should be doing more for them, or it's hard, especially when we're in this job because we're caring about people. So sometimes, especially if you're tired or you've had a really busy day or you've got lots of other things to do, if someone's saying that to you, it can be hard sometimes to not take that on board and take it very personally.
Again, it's just being objective, knowing why I'm here, and that actually at times they don't realize what they're doing, because when they get better they say sorry at times, and at times that's just the condition as it is. For example, if they have dementia and they're deteriorating, they don't realize this is what's going on, and then it's trying to find the ways to work with them, what works for them as an individual.
What's important to communicate about co-occurring disorders is the importance of an integrated, comprehensive treatment approach that is also individualized, personalized.
We're not so interested in saying, well, I'm a psychiatrist, I only do psychiatry, or I'm an addiction person, all of your problems are due to addiction, and if you just get sober, they all go away.
That process of sequential treatment becomes very inefficient, and it's a barrier to care.
I couldn't get into drug and alcohol treatment because they asked them if they took co-occurring disorders, and they said yes. And then when we told them I had active psychosis, they said, no, we don't take that.
We have to be able to link people to the other providers that can help with the physical and emotional aspects that have been impacted by these diseases.
It's setting up a system so they can get better. So you integrate care.
What I see confirmed day in and day out with my patients is that when I approach them by listening, reflecting back what I'm hearing, asking permission to give suggestions, I get a much better and more honest outcome with them.
For me, success is when an individual is functioning at their prior level, when they're now productive again.
Success is them in recovery or working towards recovery, living their best version of them.
Well, right now, success would look like for me to be independent again, to live by myself. There's not an end to it. There's no finality to it. You're recovering. You're always recovering. It's always going to be there, and that's okay.
If I wanted to encourage providers to treat co-occurring disorders, I would first and foremost tell them that their treatments are going to be more effective. Their jobs, I think, ultimately are going to be easier because the patients are going to be more satisfied with care.
Is more satisfying for the clinician and the patient because it's more efficient, you see the results more quickly, you're better able to engage the patient and retain the patient in care.
To learn more about co-occurring disorders, go to samhsa.gov/co-occurring.
Let me ask you a question. If you raise the legal drinking age, do you reduce the rates of suicide in youth? The answer is yes. We talk a lot about the negative effects or consequences of using drugs or alcohol. But one of the things we don't talk about that much is the link between suicide and substance use. In the United States today, rates of suicide among young people are increasing dramatically. Teenagers who binge drink are up to 5 times more likely to attempt suicide. And teenagers who smoke marijuana daily are up to 7 times more likely to attempt suicide. We all have inhibitions. That's the brake that stops you from doing risky things. And when you're drunk or high, that brake doesn't get turned on. What can happen is that this makes us more likely to act on suicidal thoughts. Drinking or using drugs can also increase your feelings of being distressed, feeling sad, alone, or anxious, and you may be more likely to act on those feelings in the moment. It also limits your ability to problem solve and come up with strategies that can help you feel better. Substance use may also increase suicide over the long term by increasing distress and worsening mental health problems. People with mental health problems often use alcohol or drugs to feel better, to medicate the symptoms that they're experiencing. But unfortunately, what can happen is it can make the symptoms worse, leading someone to be more likely to act on suicidal thoughts. On the flip side, depression and anxiety can also occur when you stop using drugs. During this time, you may be more likely to feel suicidal as you recover and your brain learns to function normally again. People can use drugs and alcohol for all kinds of reasons. We use it to have fun, hang out with our friends, try something new. Some people, though, as we've talked about, use it to make themselves feel better, manage feelings of depression or anxiety, or maybe even to help them focus. But it can quickly get out of hand, and it can be difficult to stop using the drug or alcohol. There can be lots of barriers why somebody doesn't seek treatment, but that's a missed opportunity, because now there are several effective treatments for teenagers that really do work. Treatment is most effective when you get it immediately, and especially as a teenager. The earlier you get treatment, the better off you'll be as an adult. So what can you do if you see a friend, or maybe you yourself are struggling with drugs or alcohol, or maybe have suicidal thoughts? You can encourage a friend to seek treatment, but doing so can be tricky. A friend can get angry with you or push you away, but they may actually hear you. Feeling isolated and frustrated and alone is often a side effect of having an addiction. When you reach out to a friend, it may be just the help they need. You can also talk to a trusted adult in a confidential way, maybe an older brother or sister, or an aunt, or even a guidance counselor. Someone who will be able to help you find the resources that your friend needs. Watching your friend struggle with drug or alcohol use or suicidal thoughts can be difficult. Be a friend, but you don't have to be a therapist. Crisis hotlines for substance use and suicidal behavior are available, so you and your friends don't have to struggle alone. These include the Crisis Call Center, the Crisis Text Line, and Lifeline Crisis Chat.
The most important warning sign that every clinician should watch out for with suicide is that suicide cannot be predicted. and that strikes people as odd. What I mean by that is all people who have mental disorder should be asked about suicide. And you should not assume that a person is not at high risk of suicide.
When patients have depression, we have to ask them about suicidal thoughts. Just like if we're treating somebody with a heart condition, we always ask about chest pain. The people who are most risk for suicide will be people who have had recent attempts at suicide. There'll be people who aren't sleeping very well, they're agitated. Alcohol and substance abuse will affect your judgment to make you more likely to commit suicide. People are more likely to commit suicide if they've had family members commit suicide. So we have to consider all these various risk factors out there.
Aside from being an older male, the greatest risk factors for completed suicide are having a psychiatric diagnosis, especially depression, bipolar disorder, schizophrenia, PTSD, having a substance abuse disorder or dependence, an eating disorder. A history of physical, sexual, or emotional abuse is an important risk factor. The recent loss of a loved one, financial stress, a serious medical illness, and access to lethal means, whether it's guns or drugs for overdose. The most worrisome experiences I have in my practice are with patients who have almost a sense of relief. Suicide becomes not only for them a way of escaping their emotional pain, but also a way to protect their family and help their family to escape from the burden that that individual in their mind is causing.
Hi, welcome to Do This, Not That. I'm Sue Self, licensed clinical social worker and behavioral health liaison manager for BJC Behavioral Health. In this segment, we're trying to understand and feel confident and competent when providing care for patients who exhibit suicidal behaviors. Suicidal patients are very often misunderstood and can evoke panic, fearfulness, and extreme caution on the part of healthcare providers. Suicide behaviors themselves are not a psychiatric disorder. Think of this as a coping method. I know this can be a strange concept, but consider this. Patients who express thoughts of or engage in behaviors with the intent of ending their own lives are often really trying to put an end to their psychological pain and their problems. They have given up on the idea that life will ever get any better, so much so that they're unable to continue to try and have lost hope.
I just can't do it anymore. I can't do it.
To tell the truth, it can get a lot less frightening when you've listened to and understand the patient. Two things will go a long way: assessment and a positive working relationship in which we do a lot of empathic listening. Not every patient who thinks or even talks about suicide will make an attempt, and not all of them need to be on psychiatric floors. You don't have to be a licensed mental health professional to help a patient in this kind of situation. If a patient is suicidal, you might observe unbearable pain, physical and/or psychological, signs of depression, the patient talking about wanting to die or to kill herself, expressed feelings of hopelessness or having no reason to live, feeling trapped or terribly alone, talking about being a burden to others, displaying extreme mood swings, showing rage or talking about seeking revenge, such as, "They'll be sorry when I'm gone" kind of statements, a prior suicide attempt. One of the difficult things about suicide risk is that it's a spectrum that ranges from low to immediate high risk, and determining where a patient's risk is on the continuum is not an exact science. So what causes someone to actually think about taking his or her own life? While some medication and medical disorders can cause depressive symptoms, suicide is frequently associated with chemical imbalances in the brain, addiction and early recovery from addiction, chronic pain, loss, sleep deprivation, alienation, guilt, and shame. So what do we do for a patient who has been thinking about suicide or perhaps even made an attempt? Remember that people in this situation can feel intolerably alone, as if no one understands, and that being understood is impossible. Establishing a positive, trusting relationship with a patient in this situation is more than half the game. I can't say that strongly enough. Be someone the patient can talk to and trust, not to judge. Remember that you don't have to have all of the answers or fix things. The best care you can give is to listen well. First, don't worry that talking about suicide with the patient will increase his risk or be suggestive. It just doesn't work that way. You may be the only one willing to have this conversation. Don't ask about suicide in the midst of gathering other information or completing other tasks. Don't try to talk the patient out of their feelings. Give them a choice of behaviors by offering options. Don't confront the patient or use guilt or shame to get them to see that suicide is not a good idea. Don't use cliches or platitudes such as suicide is a permanent solution to a temporary problem. Be warm, genuine, and sincere. Seek to understand the patient's feelings and problems from his or her perspective, even if their problems seem solvable to you. Ask questions gently, without judgment, and without implying what you want to hear. When asking the patient a question such as, "What was going on when you decided to take the pills?" wait for an answer before you ask another. Once the patient has answered, respond with empathy, such as, "All of that sounds pretty overwhelming," or, "A lot of people would be overwhelmed by that." Some questions to ask a patient are: suicide intent. What was the patient hoping for when they made the attempt, or hoping would be the outcome if they do make an attempt? How does the patient feel about the attempt now? Relieved, ashamed, more determined? If you get a short answer, ask for a longer one, such as, "Can you tell me more about that?" A desire to die. A lot of suicidal people have some ambivalence about dying. They just want the pain to stop. Ask about their plan. Does the patient have future plans to die? Ask about details and time frames. Greater detail and closer time frame generally mean higher risk. Previous attempts. This also increases risk. Psychological pain. On a scale of 1 to 5, 5 being the most emotional pain you've ever had, how are you feeling today? How about on the day you made the suicide attempt? Ask the same about physical pain if it's appropriate.
Good morning, Lou. I'm Lillian. Can we talk for a few minutes? It seems like yesterday was a really bad day for you, wasn't it?
Yeah.
When you took those pills, were you hoping that you would die?
I guess I was, at least a little bit. I just couldn't do it anymore.
Have you ever tried suicide before?
No, not ever. This is a mess.
It sounds like things were really getting to be too much for you. What was happening that you got to that point?
I lost my house. I've been so depressed. I haven't been doing well at home for a long time. And I've been turned down for so many jobs. I can't even look anymore. It was just the last straw. I haven't been good at anything for a long time. And my family needs better. And they'd be better without me.
How are you feeling about all of that this morning?
I don't know, I feel stupid. I'm so embarrassed. I mean, I couldn't even kill myself.
It sounds like you have been feeling a lot of emotional pain lately. And on a scale of 1 to 5, how much do you really want to die?
I guess at a 2, I guess. I mostly just want all these problems to go away.
I want life just to get easier. I can't deal with it all. Something really has got to give.
And so that something was you.
That something was me.
I'll bet that sometimes it seems like things just won't get better. Do you think they will or that they could?
I don't know. It's just all been getting worse and worse for a long time. I don't even know why I'm so depressed lately.
You've been sliding down this hill for a good while now. Are you still thinking that you want to kill yourself?
I don't know what else there is. I mean, things aren't going to get any better, and I don't know what else to do.
Tell me about your plans to kill yourself.
I don't have a plan right now.
You're certain?
Yeah, I just don't know what to do anymore. I can't make life work, you know?
Once you've heard enough of the patient's story to understand, tell him or her that you do. You can convey understanding without condoning the behavior. For example, with all of these things going on, I think I'm beginning to see how you could feel so overwhelmed and ready to give up. I'm also hearing that you would like to feel better or more in control of things. This can turn the story in a new direction and allow you to introduce the idea of making other decisions and accepting help.
It sounds like a desperate situation, and your family does deserve a good life. So do you. If there was something else to do, would you consider trying it?
If there's something to try, I will. I've just been feeling so out of options. Tell me what that is.
What I'd like to do is call someone up here to talk to you about it. Because I'm not the expert on these things, but I've seen people who feel a lot like you do right now, and they get better. Could I do that for you? Can I call them right now and find out when they can come up to see you?
Okay. But I don't like people messing around with my head.
They're not going to be messing with your head. There's been enough of that going on, right? I understand that you feel pretty bad right now, and things haven't started looking up yet. But let's get the ball rolling and see if we can't move things in the right direction. I'll make that call.
You're right. It's time I do something that will actually help.
Can you make an agreement with me that you won't do anything to try to kill yourself without calling for me? I'll come in, I'll check on you, the sitter will be here. But if you start feeling worse, just promise that you'll call for me.
Okay.
Research tells us that even when we don't ask all the right questions or forget some things, when we establish a positive, working, trusting relationship with the patient, the likelihood of a positive outcome increases dramatically. Combining that positive relationship with a good assessment of risk and responding appropriately is the best plan of action. Keep in mind, you don't need to be a psychiatric professional to help a person through this. You just need to know what to do. Thanks for watching.